If you take amlodipine or metoprolol every morning and you've felt more tired than you used to over the past year or two, here's a question worth sitting with. How confident are you that you actually understand what that specific pill is doing inside your body and whether the tiredness you've quietly accepted as getting older is actually coming from it? These two are both extremely common heart medications, often prescribed for similar reasons, and people frequently assume they work the same way. They don't, and the difference matters because the fatigue each one can cause has a completely different cause underneath it, which means a completely different conversation with your doctor about what to do about it. A quick note before we go further. This channel is for general education, not medical advice, and we're not your doctor. Never stop or change the dose of either medication on your own. Both are protecting your heart from real, serious risk, and we'll come back to that clearly. What we do here is read the actual pharmacology and cardiology research and translate it into plain language, the why, not just a side effect list. Stick with us, because by the end you'll understand exactly which mechanism fits what you're feeling. And that's the specific thing worth bringing to your next appointment. Before we go further, tell us your age and what state you're watching from in the comments. We read every one, and it shapes what we cover next. Here's the core distinction this entire video is built on, and it's the one thing almost nobody explains clearly. Amlodipine and metoprolol are not the same kind of drug, even though both end up lowering blood pressure and both get handed out for heart-related reasons. Amlodipine is a calcium channel blocker. Metoprolol is a beta blocker. Picture your heart and blood vessels like a car with an engine and a set of roads. Amlodipine works on the roads, it relaxes and widens blood vessels, making it physically easier for blood to flow through without touching how hard the engine itself is working. Metoprolol works on the engine, it directly slows the heart rate and reduces how forcefully the heart contracts, deliberately taking some of the workload off it. Two completely different jobs. And this is the part that matters for this video. Specifically, two completely different reasons each one can leave you feeling drained. Let's take amlodipine first, since its fatigue pathway is the more indirect of the two. Here's the mechanism. Amlodipine doesn't slow your heart rate or directly touch your energy systems at all. Its fatigue, when it happens, is usually a secondary effect of two other things we've covered on this channel before: mild fluid shifts and blood pressure adjustment. As amlodipine widens blood vessels, especially in the first few weeks after starting or after a dose increase, some people experience a temporary dip in blood pressure lower than their body is fully adjusted to yet, and that adjustment period itself can produce a generalized, low-grade tiredness while the body recalibrates. Separately, amlodipine's well-documented tendency to cause mild fluid retention and ankle swelling, which we've covered in detail before, can also contribute to a heavy, sluggish feeling in the legs that some people describe as fatigue rather than swelling specifically. Think of amlodipine's fatigue like the tiredness you'd feel for a few days after moving to a higher altitude. Your system genuinely is adjusting to a real change, and for most people, that adjustment settles down within a few weeks. If it's been months since you started or increased your dose and the tiredness hasn't lifted at all, that's the specific detail worth mentioning. Still tired months later. Not tired since starting. Now metoprolol, and here the mechanism is far more direct, which is exactly why fatigue with this drug tends to be more pronounced and more immediate. Here's what's actually happening. Metoprolol works by blocking adrenaline's effect on your heart, specifically slowing your heart rate and reducing the force of each contraction. That's the entire point of the drug for people with certain heart conditions. Taking some of the strain off an overworked heart is genuinely protective and can be life-extending. But here's the part that explains the fatigue directly. Your heart rate is also what ramps up during physical exertion to deliver more oxygen-rich blood to your muscles when you need it, climbing stairs, carrying groceries, even just standing up and moving around the house. With that ramp-up deliberately blunted by the medication, your muscles and your whole body can be left working with less immediately available oxygen delivery than they're used to, and that shows up as a heavier, more persistent kind of tiredness, often described by patients as feeling like they're moving through mud, a specific phrase cardiologists say comes up often enough to be recognizable. Research published in cardiology and clinical pharmacology literature has consistently identified fatigue as one of the most commonly reported side effects of beta blockers. As a class, with studies estimating it affects a meaningful minority of patients, more pronounced in the first several weeks after starting or increasing the dose, and often improving somewhat as the body adjusts, though for a real subset of people it persists at a lower chronic level for as long as they're on the medication. Here's a distinction worth understanding clearly, because it's the piece that actually helps you tell these two apart in your own experience. Amlodipine fatigue tends to feel more like general low energy or heaviness, often alongside ankle swelling, and it's less connected to physical exertion specifically. Metoprolol fatigue tends to show up most noticeably during activity. A walk that used to feel easy now feels like real effort. Stairs that didn't used to wind you now do, because the mechanism is directly tied to your heart's ability to ramp up under demand. If you're on one of these alone, that pattern is often the clearest clue. If you're on both together, which is common, it's harder to separate by feel alone, and that's exactly the kind of situation worth bringing to your doctor as a specific question rather than guessing at home. There's a third scenario worth naming, honestly, because it happens often enough that cardiologists specifically watch for it. Sometimes the fatigue isn't really about either drug individually, it's about the combination. Amlodipine and metoprolol are frequently prescribed together, specifically because they work on different systems and complement each other well for blood pressure and heart protection. But together, the mild blood pressure lowering effect of amlodipine and the heart rate slowing effect of metoprolol can occasionally compound into a fatigue that's more noticeable than either drug would produce on its own. This is exactly the kind of nuance a symptom checklist online can't capture, but your own doctor, looking at your specific combination and your specific readings, can consider a man in his early 70s, call him James, who'd been on metoprolol for 2 years following a cardiac event and had amlodipine added more recently for blood pressure that hadn't fully come down. Over several months, he noticed he was avoiding his usual walk around the block, telling himself he just didn't have the energy the way he used to, and assuming it was simply getting older. At a routine follow-up, when he specifically described the fatigue as worse during activity and improving when he rested, his cardiologist recognized the pattern as most consistent with the metoprolol, checked his resting heart rate, and found it was running lower than necessary for his level of cardiac protection. A modest dose adjustment brought his energy back within a few weeks, without any change to his amlodipine at all, and without any reduction in the actual heart protection he needed. Nothing about this required stopping either medication. It required a specific enough description of the fatigue for his doctor to know which lever to look at. Here's the line between a nuisance worth mentioning and something that needs prompt medical attention, stated plainly. Gradual, mild fatigue that's stable and not worsening is a nuisance worth bringing up at your next regular visit, not an emergency. But fatigue that's new, severe, or comes together with chest pain, significant shortness of breath at rest, a resting heart rate that feels unusually slow or irregular when you check your own pulse, fainting, or swelling that's rapidly worsening, is different. That combination warrants a prompt call to your doctor's office. And if there's chest pain, real shortness of breath, or fainting involved, that means calling emergency services, not waiting for the next scheduled visit. So, here's why this whole video comes down to one specific piece of language worth using at your next appointment. Instead of the vague, "I've been tired lately," which gives your doctor very little to work with, describe it specifically. Is it worse during activity or all the time? Has it changed since a specific medication was started or adjusted? And does it come with swelling, a slow pulse, or nothing else at all? That level of detail is often the entire difference between a doctor who has to guess and a doctor who can pinpoint the mechanism in one visit. Tonight's plan, in one sentence. Before your next appointment, write down exactly when your fatigue is worst, whether it's tied to activity, and roughly when it started relative to your medications, and bring that specific note with you. Before you go, does your fatigue show up more during activity or all the time regardless? Tell us below. It might help someone else recognize their own pattern before their next visit. And if this explains something your own doctor never had the 10 minutes to walk through, send it to someone in your life on either of these medications. It costs nothing, and it might be exactly the clarity they needed. One more thing before we close, because it matters more than anything else in this video. Never stop or adjust the dose of amlodipine or metoprolol on your own. For any reason, both are protecting your heart from real risk. And metoprolol, in particular, should never be stopped abruptly, since doing so can itself be dangerous and needs to be tapered under medical supervision if a change is ever needed. If fatigue comes with chest pain, real shortness of breath, or fainting, that's a call to emergency services, not a wait and see. We've covered which mechanism is likely behind your fatigue, but there's a specific time of day for taking these medications that can meaningfully reduce this exact side effect, and almost nobody's doctor has time to mention it. And that's exactly what we're covering next. Watch that one right after this.